Hello, this is Henry Silverman, and today I'd like to talk about the ethics of placebo controls when effective treatment is available. First, some background. Previously, the scientific rationale for placebo controls had been widely regarded as the gold standard for testing the efficacy of new treatments. However, two events in the 1990s raised new issues regarding the continuing unethical use of placebo controls. First, Rothman and Michaels published a study in 1994 asserted that the placebo-controlled trials were always unethical unless no effective treatment was known for the condition under study. Their assertion was based on their interpretation of the Helsinki document at that time, which stated, in any medical study, every medical patient, including those of a control group, if any, should be assured of the best proven diagnostic and therapeutic method. And hence they thought that many of the placebo-controlled trials violated this standard. Their arguments against placebo-controlled trials consisted of the following. First, providers should always act in the best interest of the patient. Second, there is no circumstance in which an effective treatment should ever be withheld from study subjects. And third, placebo-controlled trials are scientifically unnecessary because they test only significant differences from the placebo and not from the standard therapy. The second thing that happened in the 1990s involved the trials to prevent perinatal transmission of HIV in developing countries. In the 1990s, the NIH sponsored studies of short-course AZT treatment to prevent transmission of HIV from the mother to the newborn. The effective regimen consisting of long-course AZT, which had been studied and shown to be effective in studies conducted in developed countries, was not affordable in the developing countries, and hence these new studies had placebo as the control group. However, many asserted that the more intensive regimen, the long-course AZT, had already been demonstrated to be effective, and hence that was the standard of care, and hence the long-course AZT should have been used as the control group for the short-course AZT trials. Well, the purpose of most clinical trials is to determine whether a treatment is effective and safe enough. So there are different ways in which one could show that a treatment is effective. One could show superiority to placebo when there is no available effective treatment. These are known as placebo-controlled trials. Or one could show superiority against a known effective treatment, and these are known as active control trials. Or one could show equivalence or non-inferiority to an active control. Now, let me take you through Drug Development 101. Most new drugs developed to compete with existing drugs are not expected to be more effective than those already on the market. And this appears to be a surprise to most. In fact, many new drugs may have secondary advantage. This would include a more favorable toxicity profile, a more convenient dosing regimen, a more desirable formulation, or a more desirable route of administration. And hence, the primary goal is not to show superiority over standard treatment, but merely to show equivalence or non-inferiority to a competing product. Now, these active control equivalent trials, or non-inferiority trials, ACET, in these trials, patients are assigned to either a new treatment or to another treatment believed to be effective. A null result, meaning equivalency, suggests that the new treatment works because it is not inferior to a known intervention. However, as we will demonstrate in a few minutes, equivalence or non-inferiority studies are frequently inadequate to support the conclusion that the new drug is actually effective. So in equivalent trials, we want to test whether Y, the new drug, is equivalent to X, the active control. Now, if the study shows that Y is equivalent to X, the question is Y and X equally effective or equally ineffective? And whether we could assume that Y and X are equally effective depends on the so-called consistency assumption, which involves, or which means, the consistency of the effect across studies over a period of time. In other words, the assumption is that in this new study testing Y, the assumption is that X is as effective as in previous studies involving X. And if that assumption is correct, if a placebo group had been included, one assumes that X would have been shown to be superior to placebo. But this assumption that X is effective is not necessarily correct. Let's see why. Here's the problem with non-inferiority studies. So let's say in previous studies involving the drug X versus placebo, this is when no effective treatment was known, we have done several studies involving X, and the numbers here are the effect size versus placebo. So in one study, the effect of X was 10 units versus 2, and the significant was yes. Another study was only 4 versus 3, not significant. Another study showed that X was superior to placebo, 16 versus 3. Another study showed no effect of X, and another study showed that X was effective compared to placebo. I'll go over why we have varying results of drug X versus placebo. But essentially, when we compare new treatment Y to treatment X, and there is equivalency, the question still remains as to whether Y is effective. Is treatment Y effective? Well, maybe yes, if X had an effect of 8 or more in that study, but maybe no if Y had an effect of 4 or less. Without having a placebo arm in the trial, one does not know whether X was effective in this trial involving Y. Essentially, the conclusion of non-inferiority, or the conclusion that Y is effective, requires a critical assumption that the effect of the active control in this study is as good or better as in earlier studies. This is similar to the assumption made for studies with a historical control. The validity of conclusion rests on an unproven assumption of consistency of the effect of X across studies over time. And in fact, the FDA data suggests that 1/3 to 1/2 of modern antidepressant trials do not distinguish a known effective drug from a placebo. And the same thing goes for analgesics, anxiolytics, antihypertensive, hypnotics, and other type of agents. So the consistency assumption does not hold in many disease areas. In other words, if I go back, the consistency in which X is going to be effective versus placebo in every trial does not hold in every trial. And the reason for that is shown in this slide. In studies of symptom-relieving treatment, non-inferiority trials are often unreliable. This is when you compare the new treatment versus an active control. And the reason for that is that the endpoints are very subjective, like pain and depression. The symptoms wax and wane. There might be poor subject compliance. So therefore, if there's poor subject compliance with the drug X, X is not going to be effective in that study population. Also, in that study, there might have been the use of concomitant medications that might have interfered with the drug X. There might have been inclusion of inappropriate subjects, or the study was testing a totally different patient population that was less responsive to drug X. Also, we're looking at clinical at agents that have modest effect size and wildly varying response or effect rates. And also, we might be looking at illnesses that have high placebo response rates. So therefore, the difference between drug X versus placebo might be equivalent if the placebo effect is very high, happens to be very high in that study. Again, when we compare Y versus X, we don't know if we show equivalency between Y and X. We don't know whether Y is as effective as X or whether Y is as ineffective as X compared with placebo. We don't know that unless we include a placebo group in the trial. So in evaluating new drugs, placebo controls should be used when possible because of the difficulties in interpreting the results of active control trials. Also, when you do an active control trials, there's no incentive to run a clean active control trial because the poorer the trial, the more error variance there is and the higher probability of a null result. In other words, the poorer the trial, in other words, you have high non-compliance, high use of inappropriate patients, you're going to show equivalency. And if that's all you want to show, then that new drug, experimental drug, is going to be approved by the FDA. Also, placebo-controlled trials are more efficient in terms of needing only smaller numbers of patients. And hence, if you have a smaller number of patients are exposed to harm. And if you're running a trial with smaller number of patients, the costs are down. Well, let me go over more what I mean by a smaller number of subjects being exposed to harms. Let's look at the sample size. The sample size of any study is inversely proportional to the signal square. So if you're thinking that the signal between X versus placebo, if that's going to be high, then you're going to need a smaller sample size. But if you compare X versus Y, an equivalent trial, the signal is going to be small. If the signal is small, the inverse of that, you're going to need a higher sample size. So equivalent trials compared with placebo-controlled trials require larger sample size. And if you have larger sample size, you're going to expose more subjects to harm in these equivalent trials. So if you're doing a placebo-controlled trials in which one half of the patients are going to receive placebo, and in other words, no effective treatment, how could you make those studies safer? Well, one, you could have careful screening of the potential subjects. In other words, you would want to exclude patients who have in the past responded well to treatments, and you want to include patients who are not currently responding well to the drug, the standard drug they are now receiving. Also, you want to make sure you design the study so that there is a short duration of the trial, and hence a short durations of the placebo period. So we're looking at trials in terms of weeks, not months. So if there are going to be some modest harms, it's going to be over a short period of time. Also, you want constant monitoring, preferably in the inpatient setting, or if it's in the outpatient setting, you want frequent contact. And also, you want to specify the criteria explicitly for when to withdraw patients from the study if and when symptoms occur. And also, you want to have ready availability of rescue medications if symptoms of the underlying illness begin to occur. So when are placebo-controlled trials unethical? Well, it depends on the consequences of going untreated. If available treatment is known to prevent or delay death, or prevent or delay irreversible disease progression, or prevent or delay any other major harm to long-term health, then placebo treatment is generally not ethical. Now, the easy cases spans on opposite sides of the spectrum. On one side, we have drugs that have a clear impact on mortality or major morbidity. So, for example, chemotherapy for many cancers, thrombolytics for post-MI, or antiviral drugs for HIV. You would not want to have a placebo-controlled trial involving these agents because the harm of going untreated is going to be very high and hence unacceptable. Now, if you have drugs that have no impact on mortality or major morbidity, but rather have impact of a lesser variety, such as analgesics or hair growth promoters or anti-acne drugs or anti-impotent drugs, the risk of going untreated for these conditions are going to be mild or moderate at best. Now, room for debate involves the so-called harder cases. For example, there is no evidence of harm from remaining untreated, but there is a concern that harm may be possible. So, for example, being left untreated with antidepressants, are they going to increase suicides for those individuals in the placebo group? What about the asthma studies? If a patient with asthma is going to be left untreated, what is the likelihood that harm might be possible? These are the harder cases. Also, other harder cases involves illnesses in which we know there's harm from the long-term non-use of therapy, but there is reason to believe that there is no harm from short-term non-use, such as a study involving antihypertensives or a study involving lipid-lowering drugs. If individuals are left untreated for a short period of time for these illnesses, there is a consensus that there is no known harm from short-term non-use. Now, someone may ask, why would anyone want to enter a placebo-controlled trial instead of taking active treatment? So let's use depression as an example. So, for example, A is functioning well on the current drug, and that person will have no interest in studying a new drug in which he or she may be randomized to placebo. However, If a person B doesn't feel adequately treated with the current drug and has tried several other drugs unsuccessfully, he or she may be interested in entering a placebo-controlled trial in which they would be randomized to the new experimental study. Or if C is considering whether to try for the first time new drug therapy, he or she may be interested in joining a new study that involves a placebo-controlled arm. Having said that, what are the conditions that makes a placebo-controlled trial ethical? Well, one, the participants will not be exposed to excessive risks for the sake of science. At most, they would be exposed to mild or moderate harms that are irreversible. And then second condition would be adequate informed consent. Participants must understand that they may be assigned to a placebo arm. They must understand that they are going to be part of a research study and not receiving standard medical care. They understand the potential risks of being untreated, and they also know that there is the availability of treatment outside of the trial. Well, let me conclude by saying that there are two types of trials in which placebos in the control arm is ethical when effective treatment exists. First, when there is the prospect that there will be only minimal burden or no risk of serious or irreversible harm to the participants, and scientific reasons demand a placebo-controlled trial. Let me say that in the Helsinki document of 2004, this "and" had been replaced by an "or," and people were interpreting the Helsinki document as saying that placebo-controlled trials are ethical if there are only going to be a minimum burden or no risk of serious or irreversible harm. However, in the 2008 Helsinki, they replaced the "or" with the "and," so you have to have these two conditions. Placebo-controlled trials would have to meet these two conditions to be ethical. Or the other type of trial, in which we'll talk more about this when we study issues in international research ethics, the best proven therapy or the best proven standard of care is not available in the host country of the trial. Thank you very much.